Today we're going to talk about palliative care. My name is Israel A. Posner. I'm an anesthesiologist at the Dr. Horacio Audibert Hospital. Palliative care is at any point in illness for any patient, irrespective of goals of care, a complement to hospice. It's about optimal symptom management, and I must say it's a growing specialty. What palliative care is not, it's not only for end of life, just for cancer patients, for those who have stopped curative treatment. It's not the same as hospice. It's not about euthanasia, and it's not a fringe movement. Palliative care comes from the Latin word palliare, or to cloak. It is a specialized area of healthcare that focuses on relief and preventing the suffering of patients. It's not only for the dying. Appropriate for patients in all disease stages, including those undergoing treatment for curative illnesses and those living with chronic disease, as well as patients who are nearing the end of life. Let's talk a little bit about the approach for palliative care. Palliative medicine utilizes a multidisciplinary approach to patient care, relying on input from physicians, pharmacists, nurses, chaplains, social workers, psychologists, and other allied health professionals. It is very important to formulate a plan of care to relieve suffering in all areas of the patient's life. The goal of palliative care is the management of medication and treatments, and these have the effect of relieving symptoms without having a curative effect on the underlying disease or cause. This can include treating nausea related to chemotherapy, or sometimes as simple as giving morphine to treat a broken leg or aching related to influenza infection. Palliative care provides relief from pain, shortness of breath, nausea, and other distressing symptoms. It affirms life and regards dying as a normal process. It intends neither to hasten nor to postpone death. It integrates the psychological and spiritual aspects of patient care. Palliative care offers a support system to help patients live as actively as possible, offers a support system to help the family cope, uses a team approach to address the needs of patients and their families. It will enhance quality of life. It is applicable early in the course of illnesses in conjunction with other therapies that are intended to prolong life, such as chemotherapy or radiation therapy. Let's talk a little bit about assessment of symptoms. We want to introduce a method for the assessment of symptoms in patients admitted for palliative care, which is called the Edmonton Symptom Assessment Scale, or ESSAS, in which there are 8 visual analog scales of between 0 and 10, indicating the level of pain, activity, nausea, depression, anxiety, drowsiness, appetite, and sensation of well-being sometimes with the addition of shortness of breath and satisfaction of sleep. On the scales, 0 means that the symptom is absent and 10 is that it is of the worst possible severity. It is completed either by the patient alone, by the patient with nurse's assistance, or by the nurses and the relatives.
When we think about assessing symptoms in palliative care, there's a lot of things we need to consider. One of them is time constraints. We don't always have a lot of time, and busy clinicians will not use assessments if they think it's going to take up too much of their time or burden patients and families. And the beauty of the Edmonton symptom assessment system is it can be done in 30 seconds or less sometimes. It's simply 9 different symptoms, for example, pain, nausea, depression, anxiety, well-being, and a few others, with different anchors from 0 to 10, with 0 not being a problem and 10 being the worst that someone can imagine. And you ask the patient to fill it out for how they're feeling right now at this moment. There's a lot of discussion for whether it should be right now or the last 24 hours. We chose right now because even people with some degree of cognitive impairment can generally tell you how they're feeling right now, even if they can't remember what they had for breakfast. And that was a part of the rationale for choosing that. That is a way of describing it. But it needs to be understood as unidimensional. It's just a snapshot. And there certainly are a lot more ways that you can tease out the nuances of pain or well-being, for example, is set up as the quality of life question. It essentially says, given all the symptoms and psychological fears, how are you feeling right now? It's the how are you question. So in one visual analog. But it's very unidimensional. Obviously, to understand what people mean when they give you a number requires a more in-depth conversation. But sometimes the fact that people give you a high score that you may not have anticipated for depression, for example, is an opening to ask people more about that particular symptom. And of course, there's very complex assessments we can do for pain using things like the brief pain inventory or a number of scales for depression and quality of life and so on. And some people may choose to use some of those in some patients. But for the average clinician, having a simple way of doing things as a standard and considering other options if you want to do a more complex assessment is helpful. And obviously for research purposes, something like the ESAS would have limited value for someone doing a complex research study where they're trying to get at numerous complex themes. But we're trying to balance these many different things as we do clinical work and research.
Here we can see an Edmonton symptom assessment scale being filled, and we can see this one is filled in by the health professional. The problems in palliative care are being influenced by different factors, and if you talk about suffering and bothering, of course there is an influence, an emotional influence, social part of how this is being affected. Not only the physical complaints that the patients are suffering or the bothering they're having, but also being influenced by the spiritual. More specifically, when we're talking about which are the problems, we're talking about, of course, about pain, anxiety, the sense of loss, grief, anger, denial, delirium. Pain and other physical complaints, the incidence for pain in cancer patients, for instance, is 70% at any given point. And it's inadequately treated in over 30% of the cases. It's very important in the care, when we're doing palliative care, to consider speed, availability, continuity, flexibility, attention to comfort. That's very important. personal approach, respect to autonomy and dignity. Who offers palliative care? Well, of course, it's often being done in a home setting by those who give home care, the general physician, volunteers. The loved ones are often you will see either elder daughter or um, the kids and the husband. They all team up to help the patient. Sometimes the patient is in the hospital, and the nurses help. You get also in some instances the nurses they team up to do the nursing care, hospice care, and near home care. But the problem in Aruba is we have more or less all of these aspects, but it's still scattered and uncoordinated. So we should establish goals for the medical care. And when we do this, we have to consider the importance of the relationship with providers, clarifying the patient caregiver's understanding and how much they want to know, who should be present during the discussions, who should deliver the information.
I'm thinking it's either you or you. Now you because you're hooked up to a bunch of machines, or you, well, you just have that look of someone who's going to die young. I'm kidding. You're going to live forever. Or not. I mean, what do I know? I mean, I'm not psychic.
We did not like him.
I think he's funny.
She's delirious.
Mrs. Wilk, I'm Dr. Hedrick. Now, it sounds cliche, but you're going to go through what we call the 5 stages of grief, which are denial, anger, bargaining, depression, and finally acceptance. Now, I assume that you two have already entered into a conversation with Mrs. Wilk about what the process of dying is going to be like.
We were doing it right before you came in.
Oh, well, then, oh, I'm sorry. Then please continue.
All right, we will. Newbie. Go.
Oh, okay, well, yeah. Okay. Death is like a journey. A journey in a boat, and then this giant light shines down on your boat and carries you up to the heavens.
That was the ending to Cocoon.
Take it away, Coxie.
Well, the important thing about this is that we explain to the family and of course especially to the patient that they will go through usually it's a 5-stage the 5 stages of grief, which are denial, anger, bargaining, depression, and acceptance. And we will see this often played out by the patients and the family. When we're doing palliative care, it's very important to realize that there is a specific language and communication technique. Acknowledgement, it sounds like you're angry, it's very important to realize. Try to explore more. Tell me more about your why you're angry. Empathy, I can't imagine how difficult it is for you. Legitimize people. Most people would feel this way. Summarizing, to summarize, and then you summarize what has been said and done. And often it is a good tactic to fire a warning shot when you're going to give, especially when you're going to give bad news. I looked at your lab results and I think I have some bad news. I wish statements is often used. I wish the cancer had not metastasized. Delivering no more than 3 pieces of information before pausing for a break is also a good technique. Try to avoid situations where you have to withdraw care. That's why it's very important to try and never get to this point. You have to discuss these things timely, warn the family and the patients that this might happen, but you want to try to avoid it, and do everything you can to prevent it from happening. It's very important. There are studies done that say that empathy when giving information, try always to give inform the patient right away when physical conditions worsen. Have daily talks about care and treatments with the nurses, in other words the patient. Answer questions clearly. This is for the nurses and the doctors. The doctor clearly informs about the consequences of treatment. Provide clear information about the examination and their tests. Provide clear information about disease. Provide understandable information about the effects of the drugs and the treatments. Provide a schedule for talks about care and treatments with the doctors. Does palliative care really improve quality? A study after death bereavement family members interviewed 54 palliative care and 95 usual care patients were studied, and they found that 65% of the palliative care family versus only 35% of the usual care family were satisfied with care.
How do they teach you how to tell someone that they're dying? It's kind of like teaching architects how to explain why their building fell down. Do you role play and stuff?
Yeah, one of us gives the bad news and one of us gets the bad news.
What do you have to do to get an A in You're Dying 101? They grade you on gentleness, supportiveness, or a scale for measuring compassion. This buddy of mine, I gotta give him $10 every time someone says thank you. Imagine that. This guy is so good, people thank him for telling them they're dying. That's brown. I don't get thanked that often.
Most of us don't receive education on education skills and how to explain what's going to happen and talk about the prognosis of an illness. But we think it's important to get training, and by doing it with role playing, this seems to help. The competence improves when exposed more than 10 times to a specific situation. Most of us learn by watching mentors. Palliative care state of the art. We should combine compassion of when it used to be with Florence Nightingale with the technology of today. That is the optimal way of giving palliative care. That's the state of the art. Now let's talk a little bit about the ethical aspects. First of all, bodies do not suffer, persons suffer. Think about this. To allow a patient to experience unbearable pain or suffering is unethical medical practice. The central assumption on which the 20th century medicine is founded provide no basis for an understanding of suffering. Now let's compare curative versus palliative model of medicine. Curative is analytical and rational. It's like clinical puzzle solving. It's mind over body dualism. It disvalues subjectively. It's a biomedical model. It's a disease-oriented model. It discounts idiosyncrasies. It doesn't take into account every patient personally. And the failure of curative medicine is death. Now in palliative care, this is a more humanistic and personal approach. It sees the patient as a person. The mind and the body are one. It privileges subjectively. It's a biocultural model. It talks about illnesses. And it respects idiosyncrasies. It avoids unnecessary suffering. For palliative care, suffering is failure. GPs are facing calls to combat acute pain and other symptoms such as anxiety, fear, and anxiety in terminal patients. In practice, the use of and knowledge of tools such as infusion pumps and syringe pumps, accessories, specific medication and application procedures should be used and followed. I'm making a list of a GP bag of tricks, and the bag contains all the necessary tools and medications to deal with acute symptoms in palliative care. Besides pumps, in which lines and needles are also medications and other small tools and related materials present. Here we can see a Graseby MS 26 syringe pump on the right, and a patient is applying patient-controlled analgesia. So the moment that the patient feels that he or she needs pain management, it presses a button and gets a shot of the medication. The GP bag of tricks should contain the instructions for the MS-26, 2 battery pack 9-volt alkaline, not rechargeable, line 5 super needle and 110 centimeter extension, Luer lock syringe 5 milliliters, 20 of those, 5 Stabalion patches 10 by 10, and an IV 3000 9 by 7, a needle cup, alcohol swipes. These are all examples of what needs to go in the GP bag of tricks. Of course, the medication, the syringes, the needles, the gauze, the tapes, and the infusions, saline, gloves, all these things should go in the trick. Among the medication that I consider important is an antispasmodic like Buscopan, dexamethasone, Asteloside, Erectiol, Diclofenac, Haldol, Primperan, Dormicum, morphine, Nocinan. Bandages are very important. This is a list of bandages we can see. You can read this on your own time. Take some time to go through it. Maybe you can use some of the ideas.
Hey, check this chart out. This guy says he's been in pain for like 3 months.
For doctors, pain is complicated. Every patient handles it differently depending on their race,
Does what hurt?
gender,
Ow! I just bit the inside of my lip. Ah! Nothing has ever hurt so badly.
or even their sex life.
Oh, yeah, that feels good.
And since there's no way to truly gauge how much pain someone's in, we have to rely on an archaic chart.
Mr. Peel, you're about a 7 on the pain chart. Yep, you're 7.
What's a 10?
Here we have a list of palliative medication and indication and dosages. Again, you can sit in your leisure time and take a look and see which one you think is important for you to use and to have. Of course, the antispasmodics, the anti-inflammatories, the anti-anxiety medication, antiphlogistic and anti-inflammatories, non-steroidals, and Haldol for symptoms like vomiting and nausea. Of course, these are the medications that I think is important for you to consider, but maybe you would want to vary what you need and what you want to use. Most of the medications that I put in the list, if not all of them, should be available in Aruba, so you can use these whenever you think you need them. Now, this is a chart that shows the possible areas where you can put a subcutaneous needle, and of course you want to avoid sites with edema, near skin lesions. Of course you want to avoid radiated areas, sites with reduced blood flow, paralyzed limbs, difficult areas for changing clothes. So you have to be keep things practical. For anxiety, we recommend supportive counseling and of course the benzodiazepine. I personally like alprazolam because it has less of a depressing effect, but there may be other anxiolyticum that you think is convenient for you to use. For delirium, it's often very important to look for underlying causes, help the patient reorient, in other words, have a clock, a calendar, talk about what day and what day it is and what time of the day it is. Try to avoid excessive stimulation. Haldol is a good medication if they are in a delirium, and the terminal delirium you have to educate and comfort, especially the loved ones and of course the healthcare professionals that take care of the patient.
Hey, Carl. Hey, Rooney, come here for a second. Carl look a little odd to you? Is it me, or does he look like he's kind of dead?
Nope. No more than usual.
I don't know. Kind of leaning towards thinking he might actually be dead.
I guess I never saw him a lot, so it's hard for me to tell the difference.
Yeah, that's true. He never did much. Wasn't a good friend. Wasn't a good anything. Hey, there more beers in the fridge?
Oh, sorry. Last one.
Oh, that's upsetting.
For depression, I use a lot of amitriptyline, even though it does have a little bit of side effects, dry mouth and tachycardia, but it's readily available. We usually start at a very low dose of 25 milligrams a day, and it can be increased up to 150 milligrams a day gradually. Ritalin, methylphenidate, is a good medication, especially to give them appetite, and it helps against the tiredness and unwillingness to do things. For dyspnea, we recommend supplemental oxygen.
bent heel erg meer benauwd geworden hè, in het weekend. Ik denk dat we daar zo vlug mogelijk iets aan moeten proberen te doen. U hebt al morfine tegen de benauwdheid. U krijgt een drank. Ga nu een injectie morfine onderhuids geven. Proberen zo snel mogelijk wat verlichting te geven. Dan kunnen we daarna bekijken wat we in de komende dagen verder moeten doen.
Smaller doses of morphine, between 3 and 5 milligrams subcutaneously, often helps. Anxiolyticals help. Talking to the family and to the patient, reassuring them, relaxing, telling them to relax and try to distract them. Massage therapy seems to help, and amazingly, one of the tricks that we use a lot, also in the hospital, is using a fan for dyspnea.
See his chart, touchscreen, copied and highlighted. Unfortunately, Radar, I'm fresh out of Gold Star. That's your lobar pneumonia at 31. How much does this guy smoke? I don't know. You realize, of course, it's your attention to detail that impresses me most. How many packs a day, genius? Half a pack? Oh, I'm sorry. I phrased the question wrong. How many packs a day, really?
11. Now you don't know where I'm coming from. 2 or 3 packs.
Well, let's hear it. Oh, I don't smoke. 0 packs.
What test have you ordered?
Oh, I know. I was totally kidding with you.
He was. We're all in on it.
I like Will. That actually makes this harder. I ordered blood cultures and a high-resolution CT.
Well, what are you looking for?
Cancer.
When you say the word cancer, every person reacts the same way.
Excellent.
Not like that. There it is.
Patients do want to know, and clinicians should ask how much they want to know. We should explore the cultural issues, which family members are present, and how much do they want to know and ask. Clinicians should always show empathy and use the right setting to explain especially difficult situations. Now let's talk a little bit about continuous sedation. The treating team has to have sufficient expertise, and the life expectancy should be 2 weeks or less. Palliative sedation, the deliberate lowering of consciousness to a point of unconsciousness of a patient in the last stages of life. The aim of sedation is to relieve intractable suffering and not to shorten life. Of course, the patient should have a diagnosis of a terminal illness. All palliative treatment exhausted, including those for depression, delirium, and anxiety. There should be a psychological assessment by a skilled clinician, spiritual assessment, a do not resuscitate order in effect, informed consent obtained and documented, nutrition and hydration issues addressed prior to sedation. There are several types of sedation possible. Continuous sedation until death takes place in the context of end of life in patients who are dying or suffering unbearably. Or a short sedation. Here the goal can be to calm the patient, for example during the night with anxiety of fear, or to find out whether a symptom after treatment really is unbearable and untreatable. The indications for continuous sedation is untreatable symptom. None of the conventional treatments are sufficiently quick and effective and or with unacceptable adverse reaction. and the prognosis seems shorter than 2 weeks.
Now let's take a couple cases and see how we might think of them in our own clinical assessments. So Janet's a 47-year-old woman with advanced ALS. She has never married, and her only living relative is a sister to whom she has never been close personally or geographically since childhood. She has friends in the community who visit her regularly, so she is not socially isolated. She has struggled valiantly through the insidious progression of her disease until recently, when she has repeatedly expressed a desire to, quote, lay down the burdens, unquote, of her terminal condition. Her severe muscle weakness requires intermittent respiratory support. She's concerned about the possible clinical depression, that is, her clinician. And so her physician engages a consulting psychiatrist who confirms she is not clinically depressed and definitely has decisional capacity. Janet repeatedly expresses concerns about the impending loss of her dignity and control over her situation, and believes that the burdens of her life, at least to her, significantly outweigh the benefits of her struggling on until she dies from the underlying condition. Although not religious, she accepts reluctantly spiritual counseling at the insistence of her physician. This counseling, however, fails to change her overall view, which is that she wishes to have palliative sedation. And this is what she repeatedly expresses to her physician, is her request and her strong desire at this time. And by the way, she says, once you have done that for me, which I hope you will do, there is absolutely no reason to provide artificial nutrition and hydration. Should the physician honor her request? Now, it all depends, as we can see, on which guidelines and policies one follows. If one is inclined to rigorously follow the AMA policy, it's entirely within the realm of feasibility that the clinician will say that this patient is suffering from distress of an existential nature. She's not imminently dying, and therefore total sedation, palliative sedation, is not a viable option for her. And I have to go back to her, tell her I will suffer with her, pursue more zealously forms of relief for existential distress that don't involve a barbiturate coma, whereas if I rather, I'll just go back here, if I am among those who follow the guidelines of the National Hospice and Palliative Care Organization or the American Academy of Hospice and Palliative Medicine, I will say this case may well be one in which I can reasonably offer palliative sedation to this patient. Let's take another case. Joe is a 30-year-old with end-stage osteogenic sarcoma. After years of surgery and chemotherapy, cure is no longer a reasonable goal. Joe's developed myoclonus as a side effect of prolonged high-dose therapy from opioids. Despite adjuvant treatments, the pain is worsening and responds only to escalating doses of opioids that exacerbate the myoclonus. Joe's groggy but alert when his physician discusses with him and his family the option of total sedation. With support from his family, Joe provides informed consent to total sedation and to the provision of artificial nutrition and hydration. Increasing doses of benzodiazepines control the myoclonus, but the dose required precipitates a coma. Joe dies 2 days later as he remains in that coma. Was his physician's conduct ethical? Now, even some of the more conservative analysts and commentators in this area have suggested that this case is unqualifiably within all reasonable realms of palliative options of last resort, because this is what you would call sedation of the imminently dying. And they will also suggest that it can be justified by invoking the doctrine of double effect and saying that providing the barbiturate medications here that totally sedated Joe was done for the purpose of ensuring he did not suffer, and also for addressing the problem of exacerbated myoclonus. It was in no way, shape, or form a way to manage existential distress or in any way hasten his death. But if we move on to a third case, we have the patient Bill, who's 56 years old, suffers from a glioblastoma, the left frontal parietal area. Following a discussion with his family, Bill decides to forego additional radiation therapy. He urges his physician to focus on symptom management. Anti-seizure and adjuvant pain medications are administered. Bill routinely experiences focal seizures followed by severe muscle weakness. Bill expresses fear of losing control of his life and asks his physician for help to end this quickly. His physician informs him that intentionally hastening death by the administration of prescription medication is against the law in their jurisdiction. However, he says that Bill should be aware that it is within his power as an autonomous patient exercising his free will to decline further nutrition and hydration. And as a consequence of that, given his underlying clinical state, he would probably not survive more than 1 to 2 weeks. His physician promises to support such a decision and ensure that if he goes that route, his dying will be comfortable, because any palliative measures that may be necessary to address the distress from his withdrawal, foregoing of food and water, will be provided. Bill stops eating and drinking shortly thereafter. 1 week later, he becomes severely agitated, and his physician prescribes sedating medication to ensure Bill's comfort. And 2 days later, Bill dies. So the question then arises, how should we characterize Bill's death? Within the taxonomy of euthanasia, for example, from a causal perspective, what was the cause of Bill's death? And what was the physician's role in this? Now, from a direct causal analysis, the physician didn't cause Bill's death. Bill died from the lack of nutrition and hydration, more probably hydration, or perhaps from the underlying condition. It's hard to parse that out. But this and the previous 2 cases were taken from this article in the Annals of Internal Medicine by Jansen and Somazi. And they would suggest a critique of Bill's physician here as, in a sense, collaborating with Bill in bringing about his own death in a hastened form by refusing nutrition and hydration. They don't say that this is categorically wrong, but they suggest that some physicians might, in the exercise of their conscience, choose not to go this route, and their conscientious decision to decline to even offer or suggest this option to a patient should not be the subject of moral critique. I want, with your permission, to go back briefly to the first case, because there was a secondary question that we should consider. Because this case was framed the way it was as a 2-part question. The first was if Janet did not decline artificial nutrition and hydration after total sedation was provided. And I don't want to leave anyone with the idea that if she had not accepted nutrition and hydration, if she had said once I'm totally sedated. I do not want nutrition and hydration. Would this make it morally problematic in some way? I'm sorry. It was case 2 in which that was the alternative. In the case of Joe. What if Joe had said, just as Janet had done in the first case, I don't want artificial nutrition and hydration? Would this have changed the ethical posture of the case? And I would suggest to you that it would not, because it goes back to that prior point. These are two separate decisions to make, and there's nothing that morally compels the physician to provide or for the patient to receive artificial nutrition or hydration once the decision has been made freely and with informed consent on the part of the patient to request total sedation, and the physician has decided they're comfortable providing it consistent with their own sense of what ethics and professionalism require in the care of patients who have intractable suffering at the end of life.
So when we consider intractable symptoms, 54% of the patient can suffer delirium, 30%, almost 30% can have dyspnea, between 15 and 30% can have pain that is not adequately assessed and addressed, vomiting in a percentage, and exhaustion. We don't know how often, but you often see this. So as we can see here, omstanders in deze tijd weten niet meer hoe gestorven wordt. Dus moeten we niet de stervende doden, maar de omstanders scholen. These are some of the considerations. Prevent withdrawal symptoms. Install adequate equipment in the patient's home or settings. Consider a bladder catheter. Treat and prevent constipation with laxative. Treat and prevent wounds. Treat the stomas adequately, and the pulmonary sounds are very important, especially for the family, to explain the sounds and why they occur. Nurses have an important task also in providing input for the indications. Impact of sedation requires consultation and agreement with all involved. Lack of coordination and cooperation will cause unrest. Where is Aruba in palliative care right now? We're still at the fetus era. We are starting with palliative care, but I think this group has a very good intentions, and I think it's a good initiative and very important. Well, we reached the end of this talk. I hope you have enjoyed it a little bit, and of course, if you have any questions or comments, anything that I can help you with, please send me an email or give me a call.